welcome. You've tuned in to Grand Rounds presented by the Department of Psychiatry and Behavioral Sciences. Thanks for being here. My name is Jed Thompson. I am the Associate Director of Communications for the department and the host of our Grand Rounds series, so welcome. Boy, do we have a good presentation for you today. Really excited to get that started, but while we wait for folks to get logged on, I'll go over some of the basics here, a little bit of the logistics about our program, about our series. First of all, as you heard when you logged on, we are recording this presentation, so we will get this posted in our archives sometime next week. So if you want to go back and watch it again, or if you want to watch any of our Grand Rounds from the past 10 years, you can find that from the Grand Rounds page on our website. So take a look at that. Also, we're always interested in hearing your feedback. So at the end of the presentation today, as soon as the webinar is turned off, you'll see a link to our survey. We'd love to hear from you. Let us know what you think. And then finally, we've got the Q&A feature active for this webinar. So if you have any questions that you think of during the presentation today, go ahead, type those into the Q&A. I'll get those queued up, and I'm going to come back on at the end if we have some time before 1 o'clock, and we'll get those questions answered for you. Okay, and I also wanted to mention that our next Grand Rounds presentation will be February 6th, so 2 weeks from now. And for that one, we're going to learn about some of the cultural aspects of PTSD assessment and treatment. So that should be an interesting one. Please join us for that on the 6th. Okay, let's go to the next slide here. I'm going to toss it over to our department chair right now, Dr. Jürgen Unitzer, and Jürgen's going to introduce today's speaker. So I'll hop off. I'll see you all at the end. And Jürgen, I'll toss it to you now.
Very good. All right. Thank you, Jed. Happy New Year and welcome to Grand Rounds in Psychiatry and Behavioral Sciences. Today, I have the great pleasure of introducing a good friend and a former faculty member in our department as our Grand Round speaker, and that's Dr. Patricia Aryan. Pat trained and worked at UCSF before joining us as a professor here at UW, and then moving on to a position as a director of the National Institute of Mental Health Division of Services and Intervention Research. Dr. Aryan is a behavioral scientist and a mental health services researcher. She spent a couple of decades, most of her career, thinking about ways to improve behavioral health care in primary care and other healthcare systems, using people, but also using technology, using digital mental health. And she's really savvy and a real expert in ways to test these kinds of things, clinical trial design and research in this kind of a space. She's published over 200 peer-reviewed articles. She was the lead investigator on over 20 federally funded research grants. She's had funding from NIH, from the National Library of Medicine, from DARPA, from SAMHSA, and she has won several research awards and other awards for the work that she's been doing. But most importantly, I think for many of us, she's been a wonderful friend, a colleague, and a mentor for many of us here at UW and beyond. So today, Pat is going to talk with us about services and intervention research in the context of mental health in the USA. And with that, welcome, Pat. Thank you for joining us. And please have everybody else join me in extending a warm welcome to Dr. Aryan.
Thanks very much, Jürgen. That was a really wonderful introduction. And I'm very happy to be here and to have been invited to share with you my insights as a former NIH employee and division director regarding the future of services and interventions research. I'll also be sharing some new information I've had from my friends who are in the know at HHS. These are my disclosures. Since I left NIMH in April last year, I've been serving as a consultant on conducting effective clinical trials research to these organizations, as well as to individual investigators. My talk will focus on the gap and impact analysis I led at NIMH while I was the division director for services and interventions research. While it's really hard to predict what will happen to NIMH and the research it supports in the future, it is possible to make some predictions for this next year and potentially the years beyond on how NIH supports research currently and the work that DISR, or the Division for Services and Interventions Research, was conducting prior to the change in leadership at HHS and at NIH. There have been some structural changes. For instance, all review is centralized. So NIMH, for instance, used to have its own study sections. Those are all gone. There are no more pay lines, meaning that funding decisions, in my opinion, will be based less on one score and percentile and more on mission alignment with NIH. And while RFAs and program announcements that went out in January of last year are still in effect now, meaning you can apply to these as long as they're still on the website, there are some planned changes to how one applies to submits applications to NIH coming in the future, and I'll be talking about that later. To this end, I'll be discussing the future of health disparities research, technology and interventions research, and what DISR was planning on supporting and how to make that align with Robert F. Kennedy Jr.'s vision for research in mental health. So let me first address the concerns many of us have about science in the United States. The main questions on people's mind are what future HHS is proposing for NIH, how Congress is responding to that future, and what was proposed in fiscal year of 2024 for NIMH. Note that NIMH only has an acting director, and although there's an active search, that will take at least a year to complete. The acting director will likely stick to what was in the works, modified by what HHS would like to emphasize. Some plans will be put on the back burner, others will never see the light of day, and a few will be modified and emphasized. HHS proposes to consolidate the 21 institute centers and offices into 7, with cancer, aging, and infectious disease staying whole. However, NIMH is proposed to be merged with alcohol and drug abuse, with Bhattacharya seeing behavioral health as one facet of the mission to combat chronic illness. So for instance, how does depression contribute to or is a function of obesity? How does exposure to violence impact cognition and cognitive decline? A large focus of Dr. Bhattacharya's vision is around creating a data collection infrastructure to better understand the underpinnings of chronic illness, much like the All of Us study, where communities would be willing to share mobile and wearable data and share health information that could be used by AI to triangulate the causes of chronic illness. All NIH directors come to the job with a specific agenda. For instance, Monica Bertagnolli, the previous NIH director, was interested in creating learning health systems throughout the United States to focus on understanding the etiology of all illnesses, to create real-world test beds for novel treatments, and health services research to support implementation of best practices. This didn't mean she wasn't planning on funding basic science, just that any additional money she would get from Congress would go towards that mission. And I assume this is true for Dr. Bhattacharya. However, anything the NIH director does needs congressional approval. Congress has historically been highly supportive of the National Institute of Health, with the exception being during COVID and specifically with an institute director overseeing infectious disease. And they've also, one of the things I learned when I was at NIMH is that Congress had a lot of communication with NIMH and were very invested in mental health research around psychosis, the prevention of psychosis, prevention of suicide, and so forth. So as you can see here, this is that since 2017, NIMH has had an increase in its budget, the exception being when there was a continuing resolution in 2024. In 2024, however, there was a motion to increase NIMH's budget by $70 million. The NIH director, however, proposes a $40 billion reduction in the budget, an action that no one or very few people in Congress wanted or requested. Because of the massive pushback from Congress, it's unlikely that NIH will be reduced so drastically, and if it happens, there will be a fight. Moreover, it will take a long time to implement these changes. In fact, yesterday, the House voted to give the NIH a slight increase to accommodate the cost of living increases, so technically level funding, and a rejection of Bhattacharya's proposal. The bill also protects indirect costs that were negotiated by universities prior to the administration change, but it does allow for awards to be multi-year funded, meaning that all the money is awarded upfront rather than over time, which is kind of an interesting decision. So with this in mind, let's put on our positive thinking caps and turn to the future of clinical and services research. And I'm going to start with what was in play before the change in leadership, and then comment on what HHS appears to be interested in pursuing. So the first thing I did when I started NIMH was to look at our funding success relative to the other divisions in the Institute. The big takeaway for me was that each year, DISR received about 400 to 500 applications, whereas the Division for Translational Research and the Division for Neuroscience and Basic Behavioral Sciences received about 500 per cycle, so 3 times the amount of applications. In other words, very few people were submitting applications, or it could be that the proportion of researchers in effectiveness, implementation, and policy research are just a smaller group of people than in other fields, and by that nature, we would get fewer applications. However, although application numbers were lower than in other divisions, the success rates for funding were similar to the rest of the other divisions. So for instance, DISR's application success rate was around 21.5% of applications scored were funded, and that overall NIMH success rate was around 22%. So it was only slightly lower, but not significantly so. So I wanted to get a better understanding of what the barriers were to submission. In the last 18 months I was the director, I was leading an effort to better understand application challenges researchers faced in the submission and review process, making connections with other agencies such as the FDA, the Assistant Secretary for Planning and Evaluation, and SAMHSA, trying to create new communication channels with the research community, and seeing if there were ways to foster partnerships across agencies. I also wanted to develop creative ways to increase the number of new investigators and services and interventions research. To do that, I needed to get a good sense of what areas of science DISR had already funded well, and thus didn't really need that much more support, what DISR was not funding that we should have funded, and basically where the gaps were and what the barriers were to submission. This would lead to research initiatives that DISR would then prioritize. The methods we employed were to conduct a request for information from the field. I'll talk about those results in a second. An internal portfolio review of applications and awards since 2015. I picked that number partly because it was 10 years, but partly because that was the time in which the experimental therapeutics approach became a requirement for all clinical trials submitted to NIMH. And then we contracted with Westat Lab in the summer of 2024 to start a external portfolio review and a field survey of investigators, policymakers, and consumers. Unfortunately, that last part never happened. We were just ready to launch the field survey in December of 2024, and then in January of 2025, all contracts were terminated by HHS, or DOJ, I should say. So with our request for information, we sent out this request to get a sense of what does the field think about NIMH's experimental therapeutics requirement and what kind of impact they felt it had on services research in particular, implementation science as well. What outcomes were most important to collect in terms of, were we missing opportunities to measure things that were really important in the implementation of best practices, and what areas of science have we addressed well, and what the field felt we should move forward with. I know here that NIH does not permit staff to conduct surveys. We can make requests for information, but all questions must be open-ended. So that meant that we had to do a qualitative evaluation of all the responses, and this is what we did. We used a grounded theory approach with inductive coding, creating an iteratively designed code book, and using memo writing to reflect the themes that were popping up. We had 5 staff members working on the review, and about 3 rounds of coding. We had 55 respondents, and so despite a lot of announcing and nagging on my part about the RFI, we did only receive this number of responses, which is generally okay for a qualitative analysis, but the findings should be tempered since it's unlikely that there are only 55 such respondents in the US who would be impacted by decisions DISR made. Those are the types of respondents that we got. Most people felt that the experimental therapeutics approach had a purpose, mostly in treatment development and efficacy testing, but that this approach was seen as not necessary in effectiveness, implementation, or services research. It was certainly nice to have, and it makes sense for the study, if it makes sense for the study, but requiring those hypotheses sometimes didn't make any sense at all. And it made it very difficult for many people with good ideas to get past review. People did agree that it wasn't a good idea to have a black box, and we should know how things work. But by the time you're implementing an intervention in an effectiveness trial or an implementation study, you should probably have data on whether and how that intervention works. Understanding how a system level intervention works is important, but for many, it's not the most crucial question that needs to be answered. The critical questions are access, reach, cost, and feasibility of implementation. Here, to this question, most of the responses were very pragmatic. For instance, placing value on implementation outcomes over clinical, better understanding of who responds and under what circumstances. So there was a call for more moderation research or more clinical epidemiology, more functional outcomes, and what the return on investment is when implementing any best practice. And then there was also a lot of call for more pragmatic effectiveness trials. Respondents gave a lot of helpful ideas about what DISR should fund, with the top 3 areas being health equity research, research that encourages better community or system engagement, and with digital mental health and measuring the impact of social services on mental health stability. So for instance, Housing First, tied for 3rd as the topics of interest. Based on these findings, we made some changes to how we would fund applications. The first change was to increase the budget for pilot trials. The decision to do so was based on the R34 budget not having changed for decades, and pilot trials and services and implementation research generally requiring more funding to test critical protocol changes. It's capped at $250,000 a year for 3 years. I also note that the perception that R34s are somehow easier to be awarded is actually false based on our internal analysis. Based on that analysis that we ran, they are just as competitive as R01s, but for very different reasons. And R01 is competitive because of the practicalities, the approach that you're going to be using to test your questions. For the R34, it was more about public health impact. And both R01s and R34s, if they were submitted by a junior person, benefited from the bump that you get for being a first-time investigator. So that's just to clarify that decision making. The decision to move services trial to the R6133 mechanism was twofold. It was to allow time to eventually remove the requirement for the experimental therapeutics, which was the only way I was going to get around that, and to allow investigators time to develop and test the infrastructure of the partnership, or to find a new system partner should the original one need to back away, which happens very commonly in services trials. However, I just learned today that all applications sent to NIH will be in response to parent announcements, meaning that NIMH will no longer have their own announcements, but will likely specify their interests underneath the parent announcement. It is clear that there is a move to make sure that all science is centralized under the NIH director. He has also been critical of institute directors being too involved in the direction of science, which he says should come from the community and from scientists themselves. I have a hard time squaring this decision with the budget increase from Congress. So I would wait and see whether or not any of those changes are going to be put into effect. However, my colleagues at NIMH have told me that that is the plan. And so all of the work that we did last year is likely to be terminated in the near future. So with that in mind, let's look at the internal portfolio analysis. Even with the news about program announcements, there's still something to be learned from what NIMH has funded in the past and what the Institute should be supporting in the future. And I'll try to talk about this with the lens, using the lens that the MAHA movement has on the conduct of science. So in order to better understand what DISR had been focused on, we dove into what had been funded in the last 10 years to understand where the opportunities were, based on requests from Congress, from ASPE, and on the RFI, the information from the request for information, plus my own interests. The main areas we were starting with were youth mental health, health inequities, including research into older populations, and then a focus on people living with food, financial, and housing insecurities. In fact, we were about to release a council concept for clearance focused on understanding programs that would help people with mental illness who are also homeless. So this was the table that we used. We picked these 3 primary areas as our focus for the next 3 years, and then broke it down based on where we thought the important areas of research that were needed. So prevention and treatment intervention was always going to be important, but under that, we were thinking about digital strategies and how to optimize and personalize those treatments for these populations. Workforce development. So I co-chaired a National Academy of Science, Engineering, and Medicine work group on the challenges in the behavioral health workforce. And based on that, we wanted to support applications looking at training methods, incentives for to keep people in the workforce distribution issues, payment models, because there was some research coming out that a lot of mental health professionals were not accepting insurance, largely because it was undervalued as a service, how to deal with waiting lists, and then underneath that, digital strategies. I had a very loud branch chief who was really into this, so kind of like populated almost everything we did. Settings, so inpatient, outpatient, but in particular, we were really interested in the intersection of these settings and how to minimize the loss to follow-up that happens when people are handed off between, say, inpatient and outpatient, or the justice into the community settings. And then, of course, in systems and policy, we're very interested in value-based care, studying measurement-based care, how to optimize systems, and then studying how innovative models that states were implementing to address mental health issues in their community. And this is an example of how we pulled that all out from youth mental health. So this table led to the release of one of our larger program announcements on youth mental health. We looked at what areas of youth mental health we had and were covering well, which led us to areas of need investigation. Those areas were parsed into need to answer now, need to answer soon, cool but can wait, or needed more. We needed to hold a work group to discuss further what was needed. We then considered if there were other institute centers and offices or agencies who we could partner with to support the program. In fact, we had a couple of announcements where we were partnering with SAMHSA to better understand school mental health, as well as using the CCBHCs, or community, I forgot now what the acronym stands for, but they're behavioral health centers that are funded through SAMHSA block grants, and how they might be better addressing youth mental health challenges. We separated those out into questions that could be addressed using computational approaches. And because of Monica Bertinoli's interest in learning health systems, we also looked to what questions or studies that we were funding could be answered through the Common Fund HHS partnership program, and indeed use some of that Common Fund money to support a couple of initiatives that we have been in the process of funding. And so obviously needed to support all of this with literature review. So as an example, I was just talking about, we have this program announcement that's still out there, accelerating solutions to improve access and quality of empirically supported practices for youth mental health. It's a very big omnibus R01 where some of the things I was trying to do is get program staff to work together between the two branches to not just think about like, well, we need to support more effectiveness studies in these interventions, but also add on questions about implementability, cost, a return on investment, and so forth. So it wasn't separated out into these separate PAs. I do think, given the interest in youth mental health, this probably will go away because it's very specific to NIMH, but it might be repurposed as a broader announcement on solutions or interventions for addressing youth disease states. We also had a couple other cleared concepts that went through the September 24 Council, advancing research and empirically supported interventions for older adults living with serious mental illness. I don't think that that's going to see the light of day. However, this third concept, optimizing treatment strategies for adult attention deficit hyperactivity disorder, may, but it'll probably change a bit in flavor, largely because of RFK's concerns about the use of stimulants and other or non-stimulant medications for ADHD, and the perceived notion that these are being abused because of the shortages that were, for these medications back in 2023 and 2024. So now let's turn to specific areas of research that DIS are covered, starting with interventions research. There will likely be only a few changes in focus with the coming years. But keep in mind that RFK has a big say in the direction of mental health research. He is a person in recovery, and I believe has based his perspectives about mental health on AA and NA models, not to mention wellness and nutritional models that are largely considered to have a little more than an N of 1 for data support. He has publicly stated his interest in the following areas with regard to mental health. So, for instance, he's very interested in alternative treatments for depression. So even though he is anti-SSRIs, he's pro-psychedelic. So anybody who's doing this research might benefit from this vision. He's also very interested in lifestyle interventions, so exercise, forest bathing, those kind of interventions, impact on mood, nutritional psychiatry, the impact of sugar, processed foods, all of that. Can we change kids' diets in order to, address their behavior in school? Methods to increase social connection, whether that's through spiritual channels or other ways to increase social connection, and general behavioral treatments. Although he's not come out and said, I want to see more CBT out in the community. It's really more of a comment based on let's walk away from medication and into these other kinds of interventions. And he has been very clear that he would like to see more de-prescription of antidepressants. I don't know that that's a research policy as much as it is an HHS or MAHA policy. But the problem with that, or the thing that advocates could do, is to at least argue that if he's going to be pushing in that direction around the limitation of antidepressants for children, that we should at least be studying what the impact that would have on people's mental health. Or are there models of de-prescription that are better than others, that kind of thing. So this is something to consider. The NIH director is largely putting RFK's mission into practice with specific priorities focused around chronic illnesses, testing alternative treatments, replication studies, and developing measurement and surveillance opportunities to better understand health and treatment. Currently, Bhattacharya's mission is about the infrastructure and securing trust in science through community engagement and the use of computational tools to serve as alternatives to treatment research methods. So when it comes to interventions research, you can expect announcements focused on more replication studies or studies of maybe not so much alternative treatments, but other medications or older medications that are cheaper to support, more focus on alternative and generic treatments for mental health, so psychedelics, environmental interventions, activity-oriented interventions, interventions to de-prescribe medications in children and adolescents, and then more focus on behavioral wellness and environmental interventions in general. Now I'm going to turn to the social determinants of health. I know that there's been a lot of grave concerns about the future of disparities research, so let's look at specifically what Dr. Bhattacharya has had to say about this. I'll be showing you direct quotes from the official NIH director's message on the topic of health disparities and by association services research. There is a stated interest in understanding social determinants of health, but there is a call to be very measure-oriented. As you can see from this quote, investigators must employ specific and measurable concepts in health disparities research. For example, redlining and housing discrimination are clearly defined practices that can measurably impact the health of minority populations. He goes on to say that, however, broad subjective claims such as attributing worse health outcomes, and I highlight this in particular population, to poorly measured factors like systemic racism should not be presented as established background. So, of course, redlining is an example of systemic racism, and he has been told that, but this gives you a window into what may or may not be acceptable language to include in your application at the funding level. And I also have concerns about this particularly kind of like quietly embedded a particular population. While I was at NIMH, we were being told that, say an application on the African American community specifically really needed support to demonstrate that this was a unique thing to the African American community. Otherwise, you needed to include all Americans in that study. Further, he says, going forward, NIH will prioritize research that goes beyond measuring health disparities to focusing on solution-oriented approaches, which include implementing innovative evidence-based interventions and treatments that address poor health outcomes. So there does look to be room for testing and scaling interventions through research and considering implementation challenges. This last part to me seems to support research into services research. However, beyond the methods to implement best practices, it's really unclear how much of this will be focused on things like the financing of care, health policy, and so forth. This is kind of a shame, since so much of the work that DISR was beginning to do was focused on studying these models. And it's also a little surprising given that Jay Bhattacharya is a health economist, and you would think that he would have an interest in these kind of questions. Now, I've presented this slide before. I think it was in a work in progress presentation, but the key, this still hasn't changed. This is basically the areas of research that we were told to flag by DOJ to exclude. I'm a little unclear how much of this is being implemented because of all of the court cases staying these decisions. But essentially anything that focuses on workforce development to bring certain underrepresented populations into the workforce is no longer seen as priority. Anything transgender or gender minority, vaccine hesitancy or access to vaccines include, and this also included any language around education about health or health literacy. Those applications were pulled as well. International research has been, is going to be very constrained. And then environmental sciences, like mostly global warming impacts, those kind of research are not going to be supported by NIH. This is the list of terms to avoid. I can share this with you. The terms may have grown, but the implementation of these banned words, I would say, has been spotty by and large. To review applications for these terms requires a big team of people. DOJ is much smaller than it was, and even before I left, the onus to search for these terms was on program, and I do know that there was some quiet resistance to this. I advise, though, being very cautious with these terms, but don't worry too much either. If you focus on a question of importance and can say your intervention or strategy addresses a specific set of barriers that's measurable, then you should be fine. Although there's been no formal statement about technology and digital mental health focus from NIH, there has been on disparities and social determinants of health, there still remains strong interest in this topic. However, the language around this is largely on how to use technology to understand health conditions, collect larger scale data, larger scale outcomes data, and for ongoing surveillance. This will likely be largely an intramural project that will be run by the National Library of Medicine and may piggyback onto a newer version of the All of Us study. My prediction is that much of this will be intramurally run with competitions from outside sources to augment and test the validity of these methods. That right now is just my opinion. Extramurally, there are concerns about the use of digital media on brain development, obesity, and mental illness. So it's likely we'll see some more announcements focused on the safety of technology. I'll get into AI in a moment, but first let's talk about the intramural work. This is from Jay Bhattacharya's, the NIH Institute Director's webpage, and is very much describing technology as a means to an end, with several goals that are geared towards improving a sustained way to collect data and manage it and then share it. I'll get into that in a second, so that it's accessible to everyone. And then, to provide opportunities to develop computational methods and use artificial intelligence to mine this data for information, and then to strengthen the broad community in data science. The opportunities in this specific area in scientific infrastructure are studies that investigate methods to increase people's trust in the data sharing. This is a really difficult area because consistently surveys across the board have said about 50 to 60% of people surveyed indicate that they do not trust the government with their health data. An opportunity to develop data standards is another one, and one hopes this includes data security measures and consistency in hardware collection of such data. This is also challenging because many companies with devices that people are likely to buy are hard-pressed to share this information or to accommodate to regulation. Also, there's an opportunity to develop shareable data platforms. This likely will have to come from government or university or small companies. For 10 years, big companies like Google Health have promised to create such platforms that are open source, but literally nothing has happened yet, and I would be surprised if that would happen in the future. Although it's not specified in this list of goals, except for the last goal, there is definitely a strong interest in enhancing citizen science. The National Library of Medicine is central to this mission, and central to this plan is the use of AI and the development of citizen scientists. It's really unclear what extramural support there will be for this area. In May of 2025, there was a request for information about what research should look like in this area, but so far no results from that RFI have been released. But just to highlight the work being done in citizen science, there is a strong effort to involve the community as much as possible in running the science. This webpage is on the National Library of Medicine, is an example of how they'll be curating data on environmental determinants of health. And you can see the very first tab is citizen science and crowdsourcing, with classes to teach citizens on how to do this kind of research. Now, citizen involvement in science is not a new idea for NIH at all. In fact, I presented data on the potential issues leading an effort on citizen science to the National Library of Medicine about 4 years ago, based on a survey of 1,000 online participants who had lived experience with heart disease or depression. And based on these questions, we found that many people said that they would participate, however, and share this kind of information. However, you have to remember that this is a group of people who are already providing data online. So I would temper that percentage a little bit. But you could see that there was some interest with helping with data governance, like the data security and, how do you recruit people? Interest in forming research questions, which isn't new either. I mean, when we're doing community-based research, they should, obviously consumers should be involved in that. But one thing that's really interesting is that, and you can see this as a plus minus, but about 40% of people were interested in crowdsourcing data analysis. many of the qualitative comments on this particular question or finding was that most of the people who said they wouldn't do it said, I don't know how to do that. Whereas the other 40% say, oh, I do this all the time. I do my own research. We're being told to do our own research when we're looking at healthcare. So there's going to be a lot of encouragement of this kind of thing. In terms of current NIH priorities, so moving on to what you could do as UW researchers, some of the past announcements are still viable. For instance, the digital laboratories were renewed last year with the premise of these and the premise of these announcements does align with NIH's missions. So although the standards for data and metadata expires this June, given the interest of NIH generally, this may be renewed or most likely become part of a NIH-wide announcement. RFK is interested in studying the impact of technology on brain development, so there may be more basic science here that could lead to targets for intervention development. But one thing I think you should do here, if you're thinking about, say, artificial intelligence or wearables as a means of improving mental health, is to remember that DISR has been studying digital mental health and to some degree large language models since 2013, with the first RFA issued in 2012. The main issue in this research has uncovered is that there's generally poor community adoption of digital mental health tools, and even those that are evidence-driven. For instance, David Moore has consistently said that we tend to build things without thinking through if people really want these tools that we build and test, what role people feel technology should play in healthcare, and how those tools will fit or be adopted into the settings where people will access them. So let's look at AI as an example. So lots of people are using chatbots like ChatGPT for therapy. So in response, what do? Build a safer, more therapeutic AI chatbot. But do we even know why people use ChatGPT for therapy? Is it about convenience? Is it about the lack of desire to see a therapist? Is it the inability to access a therapist? Or is it that ChatGPT is a really addictive tool? Two work groups, one headed by the American Psychological Association and the other by the FDA, found that it's pretty clear that ChatGPT is so popular because it's really good at telling you what it knows you want to hear. It's basically a sycophant. Therapy is not supposed to do that. So based on that, can we ever compete with ChatGPT? Now, I'm not thoughtless here. In fact, I was also drawn into wow, lots of people use video games. What if we made them therapeutic and fun? And that model has not done well at all, because no matter how pretty a therapeutic game is, it will never be able to compete or adapt the same way commercial games can. And while I was able to get older people to play games, numerous studies found that kids hate being told what game to play. And they have a lot of choices out there. So if we don't think clearly about what people want from digital tools or AI, for that matter, we may never be able to build a safer substitute. So in 2022, my lab had conducted a large-scale survey of treatment preferences for technology across generations. And there's a lot of information from this study, so I'll just hit the main highlights about preferences in technology. Again, this is a sample of people who are participating in an online survey, and they were identified as having a lived experience with depression, so you have to temper this a little bit. But everyone did prefer in-person therapy, with older and younger adults sharing similar preferences here, and middle-aged adults more interested in telehealth and apps. Likely, this is due to the differences in free time that people experience across the generations. Most people were concerned about message-based care, largely due to privacy, but also because of questions about efficacy. And when asked about what role technology should play in mental health, most people said it should play a complementary role, not a standalone one. And that about 30% said they found that technology could be helpful in overcoming access barriers to traditional mental health. So so that's basically technology. I'm gonna end here so we have some time for questions. That with just a comment that it'll be important to do, similar preference surveys when developing AI tools, but it doesn't hurt to already consider where AI is most likely to be of good use now. Low-hanging fruit for AI is to build on what it does well and what does somewhat safely, and how those skills can be used to fix problems in the mental health system. So if you look at the current challenges, what does AI do well? Well, it could help you find treatment or a therapist who fits your profile and needs. It could help you locate services or match to providers by compiling reviews of services and products. It could help with waiting times by providing links to therapeutic information online or apps, or even provide some minimal support. And if in crisis, can help initiate suicide prevention models. It can help synthesize data and help with clinical decision making. It could also monitor outcomes and compile between session data and provide support to existing treatments based on that information. It may be a means of providing information and tracking when a patient is on a waiting list or even post-treatment. And it could be a means to support links to step down or stepped up services, much like caring letters or caring contacts, sorry. So the key takeaways from my presentation is that we will need to reorient our work some. And, you know, currently we still have the program announcements that were released last year live. I would keep your eye out on whether or not any new notices come out of NIH specifying when they're going to terminate the existing program institute-specific program announcements. But for right now, the thought is that if it's still up there, you can still, if the announcement's still up on the website, you can still apply. I would say too, health disparities is not necessarily gone, but the focus is more on factors that contribute to poor health and chronic health. And you're going to need to be very specific about what you think the barrier is for access to services to prevent chronic illness. I would say the future of mental health is still really unclear, particularly with the centralization of review and submission. And most likely technology work will be more for infrastructure or health surveillance. ARPA-H, by the way, is now its own institute or its own agency. It's been separated out of NIH. And my guess is that a lot of the work will also be at ARPA-H, which has been responsible for funding applications around technology to enhance treatment. Okay, so with that, I'll end here, and we have some time for questions and answers. And I'll end my show. Okay.
Great, thank you. So yeah, we do have plenty of time here for some question and answers. So we don't have any queued up yet. So let's give people some time to get
processing my information.
yeah, it's this process. Let that sink in for a minute. People can put those questions in the Q&A, and I'll read those out loud. So folks, go ahead and do that. While we're waiting, let's see. You touched a little bit about. You touched on citizen science. Could you maybe talk a little bit more about kind of how you see the future of citizen science in regards to how it relates to psychiatry?
Right. So, I mean, just so that people are clear what that is, the concept of citizen science is that everyday people participate in the, you know, in a variety of ways. One is sharing data. One is actually in making decisions around how that data should be shared and curated, privacy and security issues. Participation in protocol development. So it's very CBPR-like. But there's also one of the things that makes it different than CBPR is that the citizens can be scientists, so they can run their own studies, they can participate in data analysis, and this kind of came from the ability to take large, like geographic data and have individuals work together to find things, you know. It also is, I'm not surprised that RFK would be interested in this, since a lot of his early work as an environmental lawyer relied on citizens telling him, you know, we've looked into the rates of cancer in our community and it's much higher than this other community. Look, there's a factory down the road that's dumping into our rivers, you know. So that's sort of the concept of it. How that's going to play out in the mental health is, I think it's going to be interesting. There's a lot of stigma first about, like, do I have a mental illness? How much do I want to share that with the government? And I have seen like PCORI has tried to do some of this in mental health, and I don't know how successful that's been. I think it's been helpful in things like cardiac care, which is why I always use that as the comparator in these kind of studies of, participant interest in sharing data. But I do know that Mass General had a PCORnet, and it seemed very much like a bit of an echo chamber where it was like the exact same advocates in the same room that's always in the room when you're having some kind of community-based discussion, and that didn't get renewed from what I understand. Yeah.
Okay, well, thank you. Yeah, we have had some questions rolling in here now, so let me read the first one here. So do you know anything about mental health researcher representation on the centralized review committees?
Yeah, they do have to have content experts on CSR, and I asked a colleague of mine who had a application recently reviewed to send me the panel of reviewers, and there were definitely people who were mental health experts on the committee, but they're huge committees. It's going to be more work. Like, when you work for study section or review, like you would have like maybe 6 applications, and a lot of people were like, oh, that's so much work. There's fewer people reviewing more applications. So I don't know about how much more care people are going to put into the review. But yes, there's representation. In fact, NIH does have at least one representative for extramural review, Karen Gavin Evans, but I believe she's the only person there, and she's the one who would recommend reviewers to CSR based on the applications coming in.
Okay, great. Oh, Jürgen, you're muted.
Yeah, Jed, can I ask a question?
Yep, pop in.
Pat, so with the notion of things getting centralized and there being parent announcements that then each institute, and maybe it'll become a combined institute, as you said, will sort of make of that. There's, several of us have spent a good portion of our careers, making the case that mental health and behavioral health have tremendous impacts on overall health,
yeah,
and on chronic illness. So that could be an opportunity, but could also be a huge challenge and a huge risk, right? How do you look at that?
Yeah, I mean, if the way that Bhattacharya is looking at his vision for health research is that he's very interested in chronic illnesses, right? So we made the case that, like, absolutely, look at how much depression impacts chronic illnesses. And so he doesn't discard that. He's like, sure, but it's one of many things. And so I think the reason why he wants to have sort of this big source of data is that you would collect information on mental health, and it would be part of understanding how it interacts with other things like environmental factors, genetic factors, which isn't a bad thing. I mean, yeah, you should do that. But how that translates into like specific announcements around mental health is a little unclear.
So we might have to dust off some 20, 30-year-old, research on, exactly how behavioral health, affects chronic health.
Yeah, right. And you probably might have to think more team sciencey too. Like if there's an announcement that's, comes out that we want to understand the, like biological behavioral impacts on, say, obesity, you might have to piggyback onto that and be the depression expert or something.
Thank you.
Mm-hmm.
All right, so our next question is, so I heard the NIH director give a presentation that suggested an emphasis on junior investigators. So are there going to be any new or different incentives for more junior scientists other than the new and early investigator grants?
Yeah. So what my understanding of that is that, yes, he wants new investigators. It's part of this whole, if you understand his thinking about science in general, he feels like it's always the old boys who get into JAMA and, and that they've been influencing the data. And then that's why nobody trusts science. It's sort of this bigger, kind of view he has about how science has developed. So because of that, he wants to encourage more supportive junior scientists. I don't know that I've heard specific, I haven't heard specific plans. I did see a new announcement come out, and interestingly, it was from NIMH that was sort of about a general program to support junior investigators by giving them additional training, giving them additional time to learn about, scientific method. So from the extramural perspective, I don't know what's going to happen to the K awards and all of that. They'll probably be redesigned to some way to provide more support so that it's more encouragement to participate. You have to remember there's also the intramural program. So there are a lot of investigators in NIH. And I do believe he wants to clear out all the old school investigators in the institutes and hire new scientists within the NIH. So that's another big plan.
Oh, okay. Good to know. Okay. So if pharmaceutical companies reduce or withdraw from funding clinical research due to policy shift that's emphasizing non-pharmacological interventions, what entities would be sponsoring that research? And can NIH realistically absorb this role on its own?
Well, so if I remember the data correctly, yeah, I mean, this is going to be an issue because pharmaceutical companies do have some fraction of their own budget that they put towards research and development. But NIH picked up a lot of that, and oftentimes NIH were the ones who identified new compounds or new uses for existing compounds. That work is still going on, I believe. It's probably not going to be funded as much as it was in the past. So like for instance, there were all these accelerating medicine program. I don't know what's going to happen to that, but the BRAIN initiative was renewed in Congress's budget. And then through that, there's a lot of basic science in there, but there's also opportunities for discovery of new ways to manage, neurological problems. So I don't think they're going to go away completely from developing medications. I do wonder to what degree they're also going to be exploring these alternative things that you wouldn't have a pharmaceutical company necessarily explore, like mushrooms or, nutritional psychiatry or supplements, that kind of thing. You might see more calls for that.
Yeah.
Yeah. So yeah, I mean, I think Congress recognizes this is a bad idea to be reducing NIH's budget because so much of our industry is in health and we're going to end up behind the eight ball. So that's why they're like, no, we're ignoring your plans, Jay. Dr. Jay, you have to, keep things going, but that doesn't mean he will.
Right. Yeah. Okay. Let's see. I think I skipped over one up here. This person is saying, okay, such great info, but tangibly, what changes are there to this process of submitting a mental health research focused grant and its review? So shall we tell our mentees to proceed as if things are normal?
Yeah, what I would do is be cautious, right? And say things may change. But currently, RFA, well, I don't know if any of the RFAs are still up, but the program announcements are. And you can apply to that mechanism. And it's likely there'll be another round of reviews for that because some of these things are really hard to put into place. But keep your eye out because there may be a notice that comes out. So NIH produces these things called NOTs. As a mentor, I would check the website periodically or sign up to get those notices. Usually, this is not usual times, but typically when something expires, they give it another cycle before it's gone. And they honor the applications that come through. And so if they're scored well, then they may not fund as many as they were going to, but they'll fund the top 3 or something like that. So I would keep going and see what happens. But just keep your eyes peeled. Because there's also the possibility that this whole thing about getting rid of institute specific announcements might also go away too. We live in really weird times where somebody leadership can make one decision and suddenly the next day it's gone. So that's why it's like, don't postpone, your plans, but just be aware, don't be surprised if something changes.
Yeah, I mean, I know you had to edit your slides just this morning. Things change so fast. So like, who knows what the future holds?
Exactly.
Uh, okay, this person asks, do you feel that the MAHA priorities will disable or enhance the momentum of behavioral health treatment and training progress?
Okay, behavioral health. You mean like psychological interventions? So I don't know that Jay or RFK know that much about like CBT or behavioral
Yeah,
interventions like that.
yeah,
I don't know that they're even that much concerned about it. It depends on how much the consumer base or advocates start to complain about these kind of interventions as being. I mean, I've heard people say like in places like SAMHSA, CBT is toxic to my community. That reaches somebody's ear, then that becomes a priority. I think that based on this is my interpretation based on what he said, and we were actually doing this in DISR. We were starting to think about what does he mean by alternative treatments, and we recognized that that might mean so like let's say alternative treatments for adults with ADHD. We already were thinking about, are there behavioral models out there that might either augment the use of medication management or be a substitute? So like if you were somebody who was on ADHD medication as a child, do you have enough, plasticity built in that now you can move to like a behavioral model? Or how important would a behavioral model be in augmenting the ability to focus, on work or school or that kind of thing? So we were thinking there might be opportunities for sort of the treatments that we are used to being studied and supported more so than say like like medication treatments. But I do think there will be more, if this administration continues, there will be more research on the effect of exercise on mood, which has been done, right? But
yeah,
I want to
yeah,
do more of those. Food is a big deal. This administration,
yep.
those kind of things. So you'll see more of that. But you also might see a big emphasis on supplements. I mean, look at
Oh,
who's running CMS.
yeah, yeah. Okay, great. Well, okay. So we're after 1 o'clock, but there's one more question here. So let's just do this last question, and then we'll wrap it up. So the question is, what are your thoughts uh, on the access, and the acronym meaning Advancing Chronic Care with Effective Scalable Solutions model?
Mhm. Um, yeah, I mean, as long as it matches like, say that you're using that. I'm less familiar with that model, so I'm just making assumptions here.
Yeah,
But say that you're using that to accelerate access to care for underserved youth. I think you would have to be very specific about what barrier you're uncovering, right?
mhm,
So less about like, historically African American children end up in, in the justice community versus, mental health or justice service versus mental health services. You'll need to define like what's going on there and be really specific. And you might have to have a control, like a demographic control group to show, is this necessarily specific to African Americans or is it just all kids who act up or something like that?
yeah. Great. Well, Dr. Aryan, thank you for being here. Really
It's
great.
my pleasure. I hope this was not so negative, but I tried to be upbeat.
Well, it's a topic that affects a lot of people. So yeah,
Yeah.
great job.
Okay,
Thank
great.
you so much. And
All right,
everyone,
take
thanks.
care, everybody.
Bye, everyone.